Well, good morning. It's January 6th, recording this AMSA Talks with David Voursney of SAMHSA, and he is their CCBHC wizard. Welcome, David.
Thanks so much, Jason. Appreciate it.
Tell us your official title and how you got started in this work.
Sure. I'm the director of the Division of Community Behavioral Health, which is one of five divisions within the Center for Mental Health Services at SAMHSA. Our division houses for SAMHSA our work around the Certified Community Behavioral Health Clinic Initiative, or CCBHCs, as we'll say many times over the course of this event. Um, and then the other part of our work in my division is focused on the integration of primary and behavioral healthcare. So we house SAMHSA's programs around the integration of primary and behavioral healthcare, in addition to the CCBHC work in my division. I've been at SAMHSA off and on since 2005, and have worked in a number of areas. Started out in actually early childhood and school-based services, and then worked a lot in child and youth policy. Kind of broadened my focus to focus a lot on integration and adult policy. I worked at the Office of the Secretary for a little while at HHS, and then came back, worked as leading a policy team at the agency level. So I did everything SAMHSA for a while, kind of across the entire portfolio, and then came back to the Center for Mental Health Services, where I'd first started as heading up a team that focused mostly on adults with serious mental illness. Actually left government for a couple of years and consulted with states on their Medicaid arrangements, and then came back to SAMHSA in 2021 and to lead my division. Actually, the division has grown a lot, which is great. It's grown in tandem with the CCBHC initiative. But for a couple of years, my division included our work around suicide prevention and crisis in the Center for Mental Health Services. And so it's just that these issues I think are really important. Obviously, it's been a great time, recognizing that there's still a lot of work yet to be done, but just the amount of progress that's happened, development of crisis services, the launch of 988, and then I think certified community behavioral health clinics. Actually, it's one of the great fortunate accidents of history in some ways that we've developed this 988 system at the same time as we've developed CCBHCs. As CCBHCs are required not only to provide mobile crisis response, but also to provide comprehensive services and guaranteed access to anybody who needs them. And so we're developing the front door of the system through 988 for people who are experiencing a mental health or substance use crisis. And then we're also building out, the ability to respond, and then not just to respond in the day or the week of a crisis, but to respond in a meaningful way following up, where we have a CCBHC. I'll talk about this a little bit more later, but we're just, the amount of growth that's happened in the last, 7 years since the first CCBHCs were launched is I think, is a great trend and one that we hope to see continue. First, really appreciate you having me on to talk about the Certified Community Behavioral Health Clinic Initiative. And what I'm going to say now is not a surprise to anybody who's on the event today or listening to this, which is that we've been trying for a very long time to build out a community mental health services system that meets the needs of people in our communities. In fact, in 1963, President Kennedy signed the Mental Health Services Act, which was, I think, the most salient marker of our decision as a country to move towards serving people in the community and to building a community mental health system. Unfortunately, what happened since then is that we have developed a patchwork financing and administrative systems to support mental health services across the United States, and it should be no surprise that a patchwork financing administrative system has led to a patchwork of services across the country. And I think, in spite of, I think, often heroic efforts by people providing services and efforts of family members and people seeking services, the reality is that we have some areas that are providing good services and sometimes are providing strong individual services, but too often we don't provide a comprehensive set of services for people seeking care for mental and substance use disorders. The good news is that, and this is something we're actually making, I believe, some progress on through the Certified Community Behavioral Health Clinic Initiative. And so what is a CCBHC? A CCBHC is a provider organization that meets a set of federal standards and brings together a comprehensive range of services incorporating evidence-based practices and other supports based on a community needs assessment. It provides for improved access to mental and substance use disorder services, including the capacity to respond to people who are experiencing a crisis. CCBHCs are required to serve everybody across the lifespan with mental and substance use disorders that expresses a need for services. And importantly, CCBHCs must meet a set of federal criteria, which really define what it is to be a CCBHC. And I'm going to talk about those a little bit more in a second. We'll briefly mention that CCBHCs are being run through a federal partnership within HHS across SAMHSA, the Centers for Medicare and Medicaid Services, and also the Assistant Secretary for Planning and Evaluation. There's three main payment sources for CCBHCs. I'm not going to go into this a whole lot of detail, but just to say that CCBHCs started in 2017 as a part of a Medicaid demonstration program. And in that demonstration program, CCBHCs are paid for through a prospective payment system that provides cost-based reimbursement for a comprehensive package of services for individuals in Medicaid. So providers actually get paid what it costs to provide the services that people need. And then they have to provide a comprehensive package of services defined in our criteria. But there's also flexibility in that to define that service package based on what an individual community needs based on a community needs assessment. So that is one way we pay for CCBHCs. Second is that SAMHSA has developed a grant program. We were appropriated funds for the first time in 2018 by Congress. And we provide grant-based funding, $4 million at this point over 4 years, so $1 million a year to support the development of the delivery of CCBHC services and the development of CCBHCs. And the third way that we support CCBHCs is some states have gone ahead and created other pathways in Medicaid to support CCBHCs inside their state Medicaid programs. So those are the main ways that the federal government is supporting CCBHCs at this point. At this point, there's a little over 500 CCBHCs across the country, which is actually a monumental achievement considering we just started this initiative in 2017. So we started out with 66 CCBHCs across 8 states, and we're now, as I said, with over 500 CCBHCs across 46 states, the District of Columbia, and Puerto Rico. And these CCBHCs, again, can be supported as a part of a Medicaid demonstration program, which is ongoing by our expansion grants or as a part of independent state programs. And if you look at this map, you can see highlighted in yellow are the states that are participating in the Medicaid demonstration program. That's where they receive that cost-based reimbursement for CCBHCs. And then the states that are in blue here are states that haven't received or have operating at least one CCBHC expansion grant within the state. Not all of these states are statewide. We do have a couple of statewide states, but not all of the states here are statewide with their CCBHC program. So typically there's either a couple of CCBHCs in the state, or some states may have a more stronger footprint of CCBHCs in their states. We just awarded actually started in December 31st, so just a week ago, a new cohort of planning grants to bring in. So these grants are 1-year planning grants that SAMHSA has given $1 million to 15 states to help them plan to join the demonstration in 2026. So we're going to be doing another competition in 2026, and 10 more states at that point will join the Medicaid demonstration. So we're very excited to hopefully see further growth in the initiative, reaching more states and more communities. So I'm going to talk a little bit about the certification criteria now, which I think are really the key. If you want to understand what a CCBHC is, the most important thing to do is to read through the certification criteria. There's links on this slide that take you to the CCBHC page on the SAMHSA website. But I'm going to talk a little bit broadly about what the certification criteria cover. So first, CCBHCs have to provide 9 required services. I think most relevant to you all on the call is the first category, which is crisis services. So CCBHCs have 3 strands in the crisis service requirements. First, CCBHCs are required to participate in the local crisis system, whatever that looks like. So if there's a local air traffic control system that tracks a person from the point of crisis to the point where they have a crisis response and then receive services, CCBHCs are expected to participate in that local system, whatever it looks like. Second piece is mobile crisis. CCBHCs are required to provide a mobile crisis response in their service area. within 3 hours to anybody who expresses a need for mobile crisis services or comes across, and they don't have to express a need. If they have a need for mobile crisis services, the CCBHC is supposed to respond. And then finally, CCBHCs have to have an extended hours, so including evening hours, walk-in crisis capacity. So CCBHCs support outpatient or ambulatory services. They don't include inpatient or residential services, but CCBHCs should have within their CCBHC a place where a person in crisis can go, de-escalate the crisis, figure out next steps during extended business hours. There are some CCBHCs that outside of the CCBHC operate 23-hour or residential crisis systems, but that's outside of the scope of their CCBHC. And I should mention that there's also some CCBHCs that coordinate that are also 988 call centers or crisis contact centers. And then all CCBHCs are required to have care coordination agreements with their regional 988 crisis contact centers. So other services that CCBHCs have to provide include outpatient mental health and substance use services. So they have to provide care for people with mental and substance use disorders across the lifespan. That includes people with all intensities of need, whether it be someone who comes in with more routine anxiety or depression, or all the way to people with schizophrenia and other health-related social needs, and health-related social needs, I should say. And of course, the kind of the same range when it comes to substance use disorder services. CCBHCs have to provide screening, assessment, diagnosis, and risk assessment, along with person-centered treatment planning. They have to provide psychiatric rehabilitation services, so more intensive supports to support people in recovery from mental and substance use disorders, community-based mental health care for veterans, outpatient primary care screening and monitoring. So this doesn't mean that CCBHCs have to provide primary care themselves. Some of them do, but what the requirement for CCBHCs is that they ensure that a person they're serving is connected with a primary care provider, that they're doing screening and tracking the status of chronic and physical health conditions that a person is receiving, them providing care coordination to make sure that people are getting the primary and physical health care that they need, in addition to the behavioral health care that the CCBHC is providing. CCBHCs also support peer and family support services to the people they serve, or they're required to, and then they also provide targeted case management, which is intensive care coordination. CCBHCs are expected to provide care coordination to everybody they serve, but for people who are in intensive periods, such as episodes of homelessness, episodes where people might be leaving a residential or inpatient placement, or episodes where people might be leaving a jail or prison, they're expected to provide more intensive support for those individuals. Beyond the 9 required services, CCBHCs also have to meet 6 broad program requirement areas. And so CCBHCs have to meet requirements around staffing. So they have to have staffing that enables them to provide the 9 services. They have to have a medical director. They have to have staff on, that can provide care for substance use disorder, serious mental illness, and serve children and youth. And then they also have to have staff that can prescribe medications for opioid use disorder. They also have to have a number of training requirements in place. CCBHCs have to meet standards around the availability and accessibility of service. And this is really important in a crisis context because it gets to getting people care quickly following a crisis. So the first time someone comes in contact with the CCBHC should determine if that person is experiencing a crisis. If they are experiencing a crisis, they need to get them that mobile crisis response within 3 hours. If they determine that a person has an urgent need that doesn't rise to the level of a crisis, the CCBHC needs to get that person into care the next business day. If they determine that the person has a routine need that isn't urgent, isn't a crisis, then they need to see them within 10 business days. And then within 60 days, they have to complete a comprehensive assessment. Then that goes into a treatment plan and make sure the person's getting whatever they need across the 9 services. CCBHCs have to provide care coordination around the entire package of services they provide. But in addition, they have to coordinate care with a range of health and social services outside of the CCBHC. And there's a number of organizations that CCBHCs are required to reach out to create care coordination relationships with in their service area, such as federally qualified health centers, as I said, 988 crisis contact centers, inpatient and residential providers, and a number of other types of physical health providers, a number of other types of providers that are going to be interacting with the people that the CCBHC serves. CCBHCs also, as a part of their care coordination requirements, have to maintain a Office of National Coordinator compliant electronic health record system to support care coordination. I've already talked about the scope of services, these 9 required services. I'll just say that CCBHCs are required to provide services in a person and family centered way. And that I'll mention one CCBHC specific factor in the program, which is that CCBHCs do have the option of creating something called a designated collaborating organization relationship to partner with another organization to provide a portion of the required services. So the CCBHC maintains the requirement that they have to make sure these services are provided. If a DCO, designated collaborating organization relationship fails, the CCBHC is still on the hook for providing these services, but they can choose to partner with another provider organization to provide the services. This is especially important in the crisis context, and it's often in the crisis context that CCBHCs use these designated collaborating organization or DCO relationships. The reason for this is if there is an existing crisis response capability in a community, we don't necessarily want the CCBHC to replicate that. We want them to coordinate with it. But we still want to make sure that the CCBHC is assuring that people get that crisis response. And so a lot of states and a lot of CCBHCs, this is the most common way that CCBHCs use this designated collaborating organization relationship, is to partner with another organization established in their community to provide mobile crisis response. But the expectation in these DCOs is not that they're contracting out these services, but we often say it's like they're contracting in the services. They are going to need to provide care coordination around the services. They're going to make sure that there's information is being shared across the 2 provider organizations. And they want to make sure it's a seamless experience for the person receiving services, as if it was being provided by one organization. It's not simply a referral and saying, good luck. It's supposed to be very collaborative. CCBHCs also have to meet requirements around quality and other reporting. And so CCBHCs have a set of quality measures they have to report on. In addition, they're expected to engage in continuous quality improvement, which includes specific provisions around quality improvement related to suicides and overdoses. So making sure that CCBHCs are responding and always improving quality around some of those really critical events that we know people are experiencing that the CCBHCs are serving. Finally, CCBHCs have to meet requirements around organizational authority and governance. So CCBHCs have to be Medicaid providers in their states, mental and substance use disorder services. CCBHCs have to, in their governance, to represent the people that they serve. So that could either be by having a board that provides that includes 51% or more membership of people with lived experience or family members of people with mental and substance use disorders. Or they can figure out an alternative pathway that kind of meets that same goal of meaningfully incorporating people with lived experience into their governance. CCBHCs, of course, also have to meet all state requirements around licensure and certification. So this is kind of a broad overview of CCBHCs in a nutshell. There's a whole lot more information on our website about CCBHCs. And the full criteria is about 65 pages long. So I've really just given you the briefest possible summary of the criteria, but I hope that gives you a little bit more grounding on what a CCBHC is. And so I think that's my spiel. So.
Great. All good. All right, let's switch back. I'm going to need to get that 65. Can you share your slide deck with me so I can get those links?
Sure, yeah, absolutely.
Let
me stop sharing.
Yeah.
Unless you've already, there you go.
Okay, good. Feel it went okay?
Yeah, I mean, I hope it made sense.
You've clearly done it a few times.
I hope it's not sounding too rote. I do the slide deck a few times. So.
No worries. So I'm going to share this recording with a little bio of you, the slide deck link, the report link, this 65-page document link, so if people want to get into the dirty details. Anything else I should link to as well?
Just the CCBHC webpage, probably. And if you Google CCBHC SAMHSA, it should pop up. I can also send you a link for that. But I'll send that. I'll put that in the email when I send it.
Okay. So let's continue the interview. We're still recording. I'll just make the edits here and just say, asking you a little bit about how you think CCBHCs are reshaping or shaping community mental health care now.
Sure.
And then we'll just end with you saying, if you want to hear more about this, we'll share some links at the bottom of the screen.
Sure. Okay.
Well, thanks, David. That's a great overview of CCBHCs. So this seems to be a huge effort, maybe not as well known as it ought to be. How do you, from your 30,000 foot perspective, see CCBHCs as continuing to shape our community mental health world?
Sure. Well, as I said in the beginning, I think what we experience as a country traditionally is that, recognizing there's pockets of really great practice out there, that we have this patchwork system. But what a CCBHC says is, it just says, we're going to have one provider in a community that's going to be accountable for making sure that there's access to a comprehensive package of services. CCBHCs are never going to serve every single person, but I think they're there to provide that safety net to make sure that in a community that's served by a CCBHC, everybody should have a place they can go for what they need in terms of outpatient mental health and substance use disorder care. And so that's exactly what we want to do at this point. A little over, there's now CCBHCs in counties serving a little over half the U.S. population. So, I'm not saying that we've solved the problem in half the country. I think we've got a lot of work to do. But it's pretty dramatic growth considering this initiative just started in 2017. And we hope to see continued growth in the CCBHC initiative. One thing I often say is that, we provide a minimum standard in our federal certification criteria for CCBHCs, and it often takes, a couple years to get these things off the ground. And so in the first year, a CCBHC is really trying to meet those basic requirements. But if you go back to a CCBHC that's been operating for, 7 years, and you see what they've been able to do to really build out their services, to provide that comprehensive service array, to staff up, to engage in continuous quality improvement. CCBHCs every 3 years have to do a community needs assessment, and then keep on updating their programs based on that needs assessment. And what I found is that you go back to some of these organizations that have really established CCBHCs, that they're able to really provide an impressive array of services. And we've had CCBHCs, the responding to the disasters, really making a difference, and just reaching populations that haven't been served before, and then providing more comprehensive care. And that's our goal. We want this to be, we want that to be the expectation in communities across the country, and we hope that CCBHCs are a part of that.
Let me ask you a question we hadn't spoken about before. Is that Detroit just became a CCBHC D-win there? And could you tell us a little bit how you've seen that as a shaping project for them?
Sure, and I'll just be honest. We do have about 500 across the country, so I'm not gonna claim to be familiar with every single CCBHC. I can say that Michigan's program is really strong. Senator Stabenow, who is just retired, she, or is just about to retire, I should say, she was the driving force behind the development and creation of the CCBHC initiative. And she has been also a strong advocate within Michigan to support the development of their CCBHC program. They are not statewide in Michigan, but they have made an incredible footprint at this point, and I think are working towards taking the CCBHC initiative statewide. I've actually visited Michigan and a few of their CCBHCs, and I can say there's a tremendous amount of work being done. Some of the CCBHCs I visited, I saw increases in services to people experiencing homelessness, increased access to medications for opioid use treatment, increased kind of outreach in rural areas. I think every CCBHC is responding to its individual community needs. And and the exciting thing about the initiative is that either through our grant funding, or even better, when they receive that flexible Medicaid funding that provides cost-based reimbursement for a package of services, they actually have the resources necessary to provide the services. And so and again, that doesn't happen overnight, but if you're able to provide these kind of continuous stable resources and community over time, tied to these standards, tied to the goodwill and good work of the people at those organizations, they're able to do amazing things, and it just seems to keep on getting better over time.
Terrific work, David. How can people learn more about what you're doing and more about CCBHCs?
Sure. Well, there's a couple places. We have on our SAMHSA website, a CCBHC page. If you just Google, the easiest way to find it is you just Google SAMHSA and CCBHC. The web page will come up. There's a number of resources and links. There's like a short video that explains what a CCBHC is. You can also find the criteria and other materials on our page. The other thing is that, if you're an organization or if you're a state that's interested in the CCBHC, do you have a question about the initiative, you can email ccbhc@samhsa.hhs.gov. We have a mailbox. We monitor every business day, and we'd be happy to respond to inquiries and provide more information about the program.
Thank you, David. Keep up the good work.
Appreciate it.